Welcome to Radiology Beyond Borders. My name is Cecilia Ferrario. I'm a chest radiologist, and as you know, this space is designed for non-native English speakers, doctors in particular, who want to present better cases in English. Today, we are going through a rare and fascinating case, a posterior mediastinal mass with an unexpected diagnosis. So let's begin. Our patient has a history of arterial hypertension and was referred after an incidental finding on imaging. Importantly, there were no symptoms. The patient had no fever, no sweats, no weight loss. This was a completely incidental discovery. The initial study was a cardiac MRI, which revealed a posterior mediastinal mass measuring 45 by 63 millimeters. The mass was in contact with the right atrium and also the left atrium, but showed no signs of invasion. The content of the lesion was homogeneous with smooth and well-defined margins. You can see here on her chest X-ray, we have a PA view and a lateral view, and here we can see a double line. I don't know if you can see here we have a line, and here we have the other line. This one is the normal right border of the mediastinum. Here we can see the right wall of the right atrium, but this line should not be here. This is pathological, and you can see that we can define the borders perfectly. These are well-defined, sharp borders, and in the lateral view, we can see the same finding. We can see that this is in the middle and posterior mediastinum, and we can think about an extrapulmonary lesion because we can distinguish the borders of the lesion so perfectly, so well defined, so smooth. If this lesion was originated in the lung parenchyma, maybe this perfect border is not a finding that we are expecting to find. So we think, we already know because we saw the cardiac MRI, but we think we are talking here about a mediastinal lesion. As you can imagine, we did a chest CT with intravenous contrast. This is the non-contrast acquisition, and you can see that this in fact looks like a solid homogeneous focal lesion in the posterior mediastinum in a right paravertebral location, and the relationship with the lung parenchyma is one of the key findings here, because what we were talking about, this perfect border that shows us that the lesion is compressing the lung parenchyma, not infiltrating the lung parenchyma. And here you have another super important finding, that is the obtuse angle. Remember that this is not mathematics. If you have obtuse borders or obtuse angles with the lung parenchyma, you are probably seeing an extrapulmonary lesion. Meanwhile, if you see acute angles, you might be analyzing a lung lesion. So this is very helpful. With this study, we confirm that this is a posterior solid mediastinal lesion. Of course, we have an acquisition with intravenous contrast, and we can see that this lesion shows intense enhancement with some areas of low density inside that could represent necrosis. Based on these morphological findings and the location of the lesion, an initial impression of possible neurogenic tumor was suggested. So, what are we thinking at this point? The differential diagnosis for these particular lesions includes 4 main diagnoses. First, a neurogenic tumor that is a posterior paravertebral lesion that might represent a schwannoma, a neurofibroma, a ganglioneuroma. Is very likely to represent this kind of lesion, mostly because of this location. Posterior mediastinal lesions in 90 or maybe more than 90% of the cases represent a neurogenic tumor. But we also have to think other differentials. So this could be a paraganglioma, this is an hypervascular posterior mediastinal mass, may show intense enhancement like the lesion in our patient, similar to the, I don't know exactly how to pronounce, hyaline vascular variant of Castleman disease, and you will see why we're talking about this. It could be a plasmacytoma, a solitary extramedullary mass. This is not that frequent, but we have to consider this differential. It can present in the posterior mediastinum with similar imaging features. And last but not least, lymphoma, which is always a possibility when we are talking about a focal mediastinal lesion. It can present as a solitary hypervascular mediastinal mass. It is not the most frequent to find it in the posterior mediastinum. It's always more frequent to find it in the anterior or middle mediastinum, but we should consider this option when we are analyzing a focal mediastinal lesion. We did a PET-CT and the lesion showed no metabolic activity. And what helped us narrow the differential? Key clues: solitary, well-defined posterior paravertebral mediastinal mass, homogeneous content, smooth margins, no invasion of adjacent structures, asymptomatic patients without B symptoms that move us away from lymphoma, no systemic lymphadenopathy. Definitive diagnosis was confirmed by pathology after surgical rejection, and the patient had Castleman disease, a hyaline vascular variant. So this was the final diagnosis. We were shocked. To be honest with you, were certain that this was a paraganglioma. And something that I did not mention to you that you might be wondering is that this PET-CT was done with gallium dotatate. So this was not metabolically active, because we did that thinking, being almost sure that this was a paraganglioma. And the result was negative, so the lesion was biopsied, and this was the definite diagnosis. So which was the timeline? The step one for us was this incidental finding on cardiac MR. The second step for us was to perform a contrast chest CT, which showed a solid lesion in the posterior mediastinum. The step 3 was multidisciplinary evaluation. We proposed differentials focusing on the paraganglioma option. The surgeons of the team performed a surgical resection of the posterior mediastinal mass, and pathology called us to inform us that the lesion was in keeping with Castleman disease with a hyaline vascular variant. So, which were the teaching points of this case? Unicentric Castleman disease is a rare cause of mediastinal mass. The hyaline vascular variant shows intense homogeneous enhancement on contrast enhanced CT and also in MRIs with gadolinium. The posterior paravertebral location requires consideration of neurogenic tumors and paragangliomas. The definitive diagnosis requires excisional biopsy. Corneal biopsy is an alternative when resection is not feasible, which was not the case for our patient. Surgical resection of unicentric disease is curative with excellent prognosis and the absence of systemic symptoms like fever, night sweats, weight loss points toward unicentric disease. The chest is the most common location. Between 30 to 70% of unicentric Castleman cases, you will find it inside the chest. So this is the end. Thank you so much for being there on the other side with me while I was trying my best to tell you this case in detail in English. So this is where you can keep in touch with me. Remember that we have a web page specifically designed for this project if you want to be a part of it. If you want to receive an email with all the information about the case and some helpful insights about its description in English, you can go to the web page. I will leave you all the information in the description of the video, and I hope to see you in the next one. I hope this community keeps on growing, and I also hope that anytime soon you will be joining me to discuss these kind of cases. Thank you so much, and see you at the next one.